Good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Saitama, Japan, Dr. Takuma Maeda. Dr. Maeda is an associate professor at the Department of Neurosurgery in the Saitama Medical University International Medical Center in Japan. He completed his MD at Sapporo Medical University and PhD at the Graduate School of Saitama Medical University. He specializes in neurosurgery and his clinical interests are stroke, cerebrovascular disease, unruptured intracranial aneurysm, subarachnoid hemorrhage, coil embolizations, exoscopic surgery and neuroendoscopy and neuroendovascular treatment, and brain AVMs. He joined the Barrow Neurological Institute in 2023, where he concentrated on intracranial aneurysm research. He is a recipient of the Mordecai Y.T. Globus New Investigator Award at the American Stroke Association's International Stroke Conference in 2024 in Phoenix. He is also the recipient of the Brain Aneurysm Foundation's Austin L. Dunn Chair Research Grant. And we are extremely grateful to him for accepting our invitation to be a speaker at our webinars. And today he'll be talking about bridging bench to bedside translation research in stroke. The speaker for the second session of today is our very honorable guest from China, Professor Liu Chuanghong. Dr. Liu is the Deputy Chief in the Department of Neurosurgery at the Jiangsu Number 1 People's Hospital, Jiangsu Province, and Associate Professor at the Kangda College, Nanjing Medical University. He earned his Master of Medicine from Fudan University, where he was trained under Professor Shubin at the Huashan Hospital. And we're extremely honored to have him today at our webinars. And today we'll be talking about endovascular intervention strategies for vertebral artery dissection, a single center experience. The chair for the first session of today is our world-renowned skull-base surgeon and distinguished faculty from the Czech Republic, Professor Martin Sames. Dr. Sames is a professor and chairman in the Department of Neurosurgery at the Masaryk Hospital, University, J.E. Perkin J. also at the Second Medical Faculty of the Charles University. He is the president of the Czech Neurosurgical Society and vice chairman of the Neurovascular Center focused on surgery and endovascular treatment of cerebral aneurysms, AVMs, and cerebral ischemia. He is also credited for the establishment of the first anatomical skull-based laboratory in the Czech Republic and also engaged in editorial positions of various publications, being a member of their editorial boards. Altogether, he is a productive author with over 150 publications, papers, articles, and books. And throughout his career, he has held more than 135 invited speeches. We are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Professor Makoto Sakamoto. Professor Sakamoto is an associate professor in the Division of Neurosurgery at the Department of Brain and Neurosciences, Faculty of Medicine at the Tottori University, Japan. He is an important member of the Japan Neurosurgical Society as well as the Japan Society for Neuroendovascular Therapy. He is a specialist and instructor of the Japan Neurosurgical Society, specialist and supervising doctor of the Japanese Society of Neuroendovascular Therapy and Japan Stroke Society. We are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today. Straight away go to the lecture of Professor Takuma Maeda. Dr. Maeda, please.
Yes, so thank you very much for the kind introduction, Dr. Roger. My name is Takuma Maeda from the Barrow Neurological Institute. Today, I'd like to share some of our translational research in the field of stroke, with a particularly focus on intracranial aneurysms and subarachnoid hemorrhage. I am currently in my 11th postgraduate year. After completing my training in cerebrovascular surgery and endovascular neurosurgery in Japan, I transitioned to basic research to address clinical questions that arise in daily practice. My goal is to become a physician scientist who bridges the gap between bench and bedside. First, I'd like to discuss the conceptual differences between human physiology and pharmacology versus the basic science of cerebrovascular disease. Human physiology and pharmacology focus on understanding biological mechanisms and therapeutic responses directly in humans, often using clinical data, patient samples, or pharmacological interventions. These studies are crucial for identifying clinically relevant patterns and treatment effects. In contrast, the basic science of cerebrovascular diseases relies more on experimental models, especially animal studies, to explore the underlying molecular and cellular mechanisms of disease. This approach allows us to test hypotheses in a controlled environment, which is essential for understanding causation. So, when we think about human tissue studies versus animal studies, each has its strengths and limitations. Human tissue studies give us direct insight into disease pathology and help us confirm that findings are relevant to patients. However, these studies are generally limited to observational data. They can show associations, but not necessarily causation. Animal studies, on the other hand, allow us to manipulate specific genes, molecules, or environmental conditions. This makes it possible to test whether certain biological changes actually cause disease development or progression. Therefore, these two approaches complement each other. Human studies ensure clinical relevance, while animal models help us establish mechanistic causality. So, our main focus is on the formation and rupture of intracranial aneurysms. This figure illustrates the disease course of an intracranial aneurysm. Aneurysms are first formed and may then grow over time. Some aneurysms remain stable for years, while others continue to enlarge or become unstable. These are the ones that are at risk of rupture. So, we are interested in why and how aneurysms form and grow. For us, the more important questions were why and how do aneurysms rupture? And importantly, can we use pharmacological therapy to prevent aneurysm rupture? Our idea is that by providing a short-term pharmacological treatment, we might be able to alter the natural course of the disease, shifting it from a progressive rupture-prone state to a more stable condition. There is a well-established rat model of intracranial aneurysm that was developed by Dr. Nobuo Hashimoto in the late 1970s. This model involves including renal hypertension, administering a lysis oxidase inhibitor, and performing unilateral carotid artery ligation. By combining these three interventions, he was able to induce large aneurysm formation in the posterior circulation. In this model, aneurysms typically form within 3 to 6 months. Although it takes some time, the resulting aneurysms are quite impressive in both size and morphology. However, these aneurysms did not rupture. Therefore, we could not use this model to study the mechanisms of aneurysm rupture. In addition, it is difficult to utilize the transgenic or knockout animals as long as we are working with rats. He used rats because they have complete circle of release, whereas mice do not. Nevertheless, his mentees attempted to adapt this model to mice. In this mouse model, they observed a small vascular change at the bifurcation of the olfactory artery arising from the anterior cerebral artery. The image on the right shows the vascular alteration they identified. They referred to this microscopic finding as an aneurysmal change, but it did not meet the criteria for a true aneurysm. Moreover, this microscopic aneurysmal change did not rupture. So my mentor, Dr. Hashimoto, developed his own mouse model of intracranial aneurysm. This model was designed to produce large aneurysms with a high incidence, a short induction period, and most importantly, spontaneous rupture. There are two major factors associated with human intracranial aneurysms. The first is hypertension. It is well known that systemic hypertension is associated with both the formation and rupture of intracranial aneurysms. Hypertension is a well-known risk factor for aneurysmal rupture. The second factor is disruption of the elastic lamina. Disruption of the elastic lamina is a histological hallmark of human intracranial aneurysm. To induce chronic hypertension in mice, Dr. Hashimoto utilized the Doka-salt hypertension model. Doka, or deoxycorticosterone acetate, is an aldosterone analog that increases blood pressure by promoting sodium and water retention. To disrupt the elastic lamina, he used a single injection of elastase into the cerebrospinal fluid. The enzymatic activity of elastase in the CSF lasts for approximately 2 to 6 hours. So his idea was that combining systemic hypertension with a single dose injection of elastase into the CSF could induce intracranial aneurysm formation in mice. In fact, he was able to induce aneurysm formation by combining systemic hypertension with a single injection of elastase into the CSF. In this model, 6 to 80% of the mice developed aneurysms during the first 7 days, and 70 to 80% of the aneurysms rupture within 2 to 3 weeks. To detect aneurysmal rupture in a mouse model, we monitor neurological symptoms, particularly motor deficits. These include body weight loss of more than 2 grams in 24 hours, flexion of the torso and forelimbs when lifted by the tail, circling or leaning to one side, and lack of spontaneous movement. As shown in the graph, the onset of these symptoms correlates closely with aneurysm rupture, and as confirmed in the image. Importantly, intracranial aneurysms in this model closely resembled human intracranial aneurysms. The immunohistochemical staining demonstrates marked inflammatory cell infiltration. Here, CD45 staining indicates the presence of leukocytes, and CD68 staining highlights macrophage accumulation within the aneurysmal wall. These inflammatory changes are quite similar to what we observe in human aneurysm specimens. Overall, this model successfully reproduced both the morphological and inflammatory features of human intracranial aneurysms. This model has become known as another Hashimoto model of intracranial aneurysm and has been utilized by researchers around the world. Using this model, we have found several potential therapeutic targets for the prevention of aneurysmal rupture. Among our current projects, I'd like to highlight the topic of aging and cellular senescence because it is well known and relatively easy to understand. Okay, let's move on to the second topic of today's presentation, aging and aneurysm rupture. Aging is an independent risk factor for intracranial aneurysm rupture. This graph shows an age-dependent increase in aneurysm rupture. But the mechanisms by which aging promotes aneurysm rupture remain poorly understood. The number of senescent cells increases with age. Senescent cells have reached their finite number of division, but do not die. Senescent cells secrete senescence-associated secretory phenotypes, SASPs, which include inflammatory cytokines and vascular remodeling factors, potentially explaining the age-dependent increase in aneurysm rupture. Senescent cells accumulate in human intracranial aneurysm in a preliminary study. This figure shows a human intracranial aneurysm stained for the senescent marker P16 and the smooth muscle cell marker SM22. As shown by the white arrowheads in the right figure, the accumulation of senescent cells has been observed in the human intracranial aneurysm. Therefore, we hypothesized that aging promotes aneurysm rupture through SASPs. Again, as a result of aging, the number of senescent cells increases in aneurysm wall. Senescent cells promote secretion of SASPs, such as pro-inflammatory and tissue remodeling cytokines, that can cause aneurysm rupture. First, we directly tested whether aging increases the aneurysm rupture rate. Second, we tested whether the elimination of senescent cells prevents aneurysm rupture. Finally, we tested the effects of senescent cell elimination on SASPs using real-time PCR. Again, to induce intracranial aneurysms in mice, we combined systemic hypertension and elastase injection into the CSF. Aneurysm formation happens during the first 7 days. Aneurysm rupture develops during the second and third week. In this model, rupture rate is approximately 70 to 80%. This figure shows representative aneurysms in a model. The middle panel shows the unruptured aneurysm. The right panel shows the ruptured aneurysm. To investigate the role of senescent cells, we utilized P16 3MR mice. These mice have trimodal receptor fused to the promoter of the P16 gene, allowing the detection, isolation, and selective elimination of senescent cells. Ganciclovir treatment of these mice eliminates senescent cells. Here is the mechanisms by which ganciclovir treatment can eliminate senescent cells in this model. In these transgenic mice, the herpes simplex virus tymosine kinase gene is expressed selectively in P16 positive senescent cells. This selective expression is driven by the P16 promoter, which becomes active when cells enter senescent state. When ganciclovir is administered, herpes simplex virus tymosine kinase phosphorylates ganciclovir to form ganciclovir monophosphate. Subsequent phosphorylation by cellular kinases produces ganciclovir toripho- triphosphate, the active site toxic form. This activated gancyclovir triphosphate is incorporated into the genomic DNA, causing DNA chain termination and ultimately leading to cell death. Importantly, only cells expressing herpes simplex virus tymizin kinase, that is, the senescent cells, can convert gancyclovir into its toxic form. As a result, non-senescent cells remain unaffected. Again, therefore, administration of ganciclovir in this transgenic mouse leads to selective elimination of senescent cells. As a first step, we tested whether the aging increased the aneurysm rupture rate. We compared aneurysm formation and rupture rates between aged mice and young mice. These graphs show the aneurysm formation rate in male and female mice. White birds represent young mice, and black birds represent aged mice. Aged mice had a higher aneurysm formation rate than younger mice in both sexes. These graphs show the aneurysm rupture rate. As you can see, aged mice significantly increased the rupture rate in both sexes. As a next step, we tested whether the elimination of senescent cells prevents aneurysm rupture. To eliminate the senescent cells, we utilized the P16-3MR mice, which I explained before. There was no significant difference in aneurysm formation rate in both sexes. The white birds represent the vehicle group, and the black birds represent the ganciclovir treatment group to eliminate the senescent cells. These graphs show the rupture rate. As you can see, the elimination of senescent cells by ganciclovir reduced the aneurysm rupture rate, again supporting our hypothesis that the aging promote aneurysm rupture through the senescent cells. Finally, we tested the effect of senescent cell elimination on SASPs using real-time PCR of the cerebral vasculature. Ganciclovir treatment in P16-3MR mice successfully eliminated senescent cells. This graph shows the RNA expression of P16 as a senescent marker. Elimination of senescent cells significantly reduces SASPs, such as pro-inflammatory cytokines and tissue remodeling cytokines. These graphs show the RNA expression of pro-inflammatory cytokines, such as IL-1 beta, IL-6, and TNF-alpha, and tissue remodeling cytokine, MMP9. So in this study, we have shown that aging promotes aneurysm rupture. Our data have also shown that the elimination of senescent cells prevents aneurysm rupture. In addition, the elimination of senescent cells reduced the SASPs, such as pro-inflammatory and tissue remodeling cytokines, leading to prevention of aneurysm rupture. In conclusion of this study, aging promotes the aneurysm rupture through senescent cells and SASPs. Elimination of senescent cells prevents aneurysm rupture by reducing aneurysmal wall SASPs. Again, our research focuses on the mechanisms and pharmacological prevention of aneurysm rupture. However, it is unlikely that we will be able to completely prevent aneurysm rupture even after developing pharmacological interventions. So we are also focusing on pharmacological treatments aimed at improving long-term outcomes after subarachnoid hemorrhage. Okay, let's move on to the third topic of today's presentation. We are investigating the effect of a new drug, a novel brain-penetrant manganese porphyrin-based SOD mimic, on long-term outcomes after subarachnoid hemorrhage. Oxidative stress plays an important role in subarachnoid hemorrhage. After subarachnoid hemorrhage, excessive generation of free radicals and reactive oxygen species occurs, leading to oxidative stress. Oxidative stress causes apoptosis and inflammation in the brain and worsens neurological outcome. SOD, superoxide dismutase, plays a central role in the defense against oxidative stress. SOD is an endogenous enzyme that converts superoxide to hydrogen peroxide. Hydrogen peroxide is further converted to water by GPX and catalase, leading to the reduction of oxidative stress. Thus, SOD, GPX, and catalase are all important for the defense against oxidative stress. MNPO5 is a novel manganese porphyrin-based SOD mimic. MNPO5 acts as SOD and also as GPX and catalase. This study aims to evaluate the translational potential of MNPO5 for the treatment of subarachnoid hemorrhage. There were critical issues in previous preclinical studies that underpinned clinical translation, including inadequate demonstration of BBB penetration, insufficient assessment of drug concentration, and biological activity in the brain tissue. So we first measured the PK profile of the drug. As you can see, MNPO5 penetrates far better than previous compounds. These graphs show the enzymatic activity of SOD, GPX, and catalase. As you can see, MNPO5 indicated by green shows stronger anti-free radical activity than NXY059, which failed in clinical trials. We also conducted a safety study for MNPO5 because SOD mimics can cause dose-dependent hypotension by lowering peroxide levels and preserving nitric oxide, thereby enhancing vasodilation. This graph shows blood pressure in each dose group. As you can see, up to 10 mg per kilogram MNPO5 did not cause hypotension, but 20 mg did. Based on this safety study, we determined the experimental dose of MNPO5 in mice with subarachnoid hemorrhage. Taken together, we hypothesized that MNPO5 would improve long-term outcomes in subarachnoid hemorrhage without adverse effects. First, we tested whether MNPO5 improves 7-day neurological outcomes after subarachnoid hemorrhage. Second, we tested whether MNPO5 improves 7-day cognitive function after subarachnoid hemorrhage. Third, we tested the effect of MNPO5 on oxidative stress as a mechanism study. To test our hypothesis, We used a well-established mouse model of subarachnoid hemorrhage. Subarachnoid hemorrhage was induced by endovascular perforation. To ensure intraoperative confirmation, subarachnoid hemorrhage is confirmed by both decreased cerebral blood flow and respiratory distress. The induction of subarachnoid hemorrhage in mice requires microsurgical techniques, which neurosurgeons are particularly skilled at. This may go beyond the realm of basic science, but I'd like to show you an actual video of the procedure. First, a midline incision is made on the anterior neck of the mouse, and the submandibular glands are carefully separated along the midline. Next, the common carotid artery running alongside the trachea is identified. After isolating the common and internal and external carotid arteries, these vessels are secured and temporarily occluded. The external carotid artery is then incised and the 5-0 suture is inserted towards the common carotid artery. After that, I flipped the suture towards the ICA and advanced the suture. When the suture is advanced approximately 11 millimeters, it reaches the tip of the internal carotid artery, where puncture is performed. At this point, a slight resistance may be felt, but it is sometimes difficult to perceive. Once subarachnoid hemorrhage occurs, cerebral blood flow decreases due to a sudden rise in intracranial pressure. Finally, the suture is withdrawn. Okay, using this model, first, we tested whether MNPO5 improves 7-day neurological outcomes after subarachnoid hemorrhage. MNPO5 improved the overall neurological outcomes after subarachnoid hemorrhage. These graphs show the composite neurological score that is widely used in the evaluation of subarachnoid hemorrhage. In this scale, higher score indicates better outcome. As you can see, mice treated with MNPO5 had significantly higher scores compared to vehicle group over 7 days. Next, we utilized the Rotarot test to evaluate the effect of MNPO5 on motor coordination in mice with subarachnoid hemorrhage. Mice were placed on an accelerating rotating rod, and the latency to fall was recorded. MNPO5 also improved motor coordination after subarachnoid hemorrhage. These graphs show the result of Rotarot test for the evaluation of motor coordination. As you can see, mice treated with MNPO5 showed better Rotarot performance compared to the vehicle group on days 5 and day 7. As a next step, we tested whether MNPO5 improves 7-day cognitive function after subarachnoid hemorrhage. Because depression, anxiety, and memory impairment are commonly observed consequences after subarachnoid hemorrhage, we evaluated these parameters using open field test and Barnes-Maze test. First, we conducted the open field test. In this test, mice were placed in the chamber and allowed to explore freely for 5 minutes. Under normal conditions, mice actively explore the entire area of the chamber, whereas depressed mice tend to remain close to the peripheral zone. Left figures show the heat map, and right graphs show the time spent in center zone, as an indicator of depression and anxiety. As you can see, there was no difference in time spent in center zone, indicating that MNPO5 did not affect post-subarachnoid hemorrhage depression and anxiety. Next, we utilized the Burns maze. This is for the evaluation of post-subarachnoid hemorrhage memory impairment. The Burns maze is a round platform with many holes around the edge, but only one leads to a hidden escape box. Mice were put in the center of the maze and were allowed to escape to the hidden escape box 4 times for 5 continuous days. Left figures show heat maps and traces of mice in the Burns maze. Right graph shows the escape latency to the hidden platform over 5 days. As you can see, there was a significant differences in escape latency between the groups, indicating that MNPO5 improved memory impairment after subarachnoid hemorrhage. Finally, we tested the effect of MNPO5 on oxidative stress as a part of a mechanistic study. These graphs show the messenger RNA expression of SOD123. As you can see, mice treated with MNPO5 showed significantly lower level of SOD123. These results may be used as a surrogate for oxidative stress levels. However, because MNPO5 is an SOD mimic, it is also possible that endogenous SOD was just suppressed. So, to further investigate the effect of MNPO5 on oxidative stress levels, we measured the well-known oxidative stress markers by liquid chromatography. In these scales, higher ratios indicate lower oxidative stress. As you can see, mice treated with MNPO5 showed significantly higher levels of these ratios, indicating lower oxidative stress levels in the treatment group. In this study, we have shown that MNPO5 improved 7-day neurological outcomes after subarachnoid hemorrhage without notable side effects by reducing oxidative stress at the target site. Our results serve as a basis for future clinical trials using MNPO5 to improve the neurological outcomes of subarachnoid hemorrhage. I believe there is a real hope that we can translate our animal findings into clinical applications for patients with intracranial aneurysm and subarachnoid hemorrhage. This is the direction we are aiming for. Yeah, nothing can be done alone, and I would like to express my sincere appreciation to all of our lab members and collaborators. I would also like to acknowledge the generous support from the NIH, the Brain Aneurysm Foundation, the Barrow Neurological Foundation, and the Japan CNS. I'd like to express my deepest gratitude to Dr. Katsumi Takizawa, who inspired me to become a neurosurgeon. I'm also deeply thankful to my father of neurosurgery, Dr. Hiroki Kriter, and my father of research, Dr. Tomoki Hashimoto, for their continuous guidance and support. Thank you very much.
Thank you very much, Maeda Sensei. That was very wonderful. And we came to know a lot of different aspects of research in aneurysm that you have been a part of. We can open this for discussions. We can invite comments. Dr. Liu, would you like to ask something?
Yeah, thanks, Dr. Aida, for a nice talk. It's really exciting to see the advances that hopefully it can be done soon in the human trial. My question regarding trial that suppress a senescent cell, you have shown that it reduced the ruptured risk. May I know that did you follow up with tissue staining, whether there's a reduction in the senescent cell in the model with less ruptured compared to more ruptured? My second question, do you see beyond the risk of rupture, is there any evidence to show there's a remodeling or regression of aneurysm formation? Because we also hope those with aneurysm we eventually normalize if there is possibility without any surgical treatment. Thank you.
Dr. Liu, thank you for your wonderful question. I think that's really good questions. For the first question, yeah, actually, we did the histology study for using the cerebral vasculature and the aneurysms from our animal experimental model. But due to the limited time, I didn't show today. Yeah, actually, we confirmed the reduction of P16 as a senescent marker. And we also used lead fluorescent protein because, again, in this model, I mean, P16 3MR mice has a lead fluorescent protein under the promoter of P16. So without any staining, we can still see the senescent cells by focusing on the lead fluorescent protein. So we double-checked reduction of the staining level of the P16 and levels of the lead fluorescent protein. And there was a significant reduction in the ganciclovir treatment group, indicating that treatment with ganciclovir with this model successfully eliminated or reduced the senescent cells. For the second questions, maybe that whether we saw the remodeling of the aneurysms forming to the normal vessel structure or something. Unfortunately, in my personal level, I didn't see such a remodeling showing the, aneurysm forming to the normal vessel structure. So yeah, I'm afraid I don't have answer to your second question, but hopefully we can see such a remodeling in the future. Yeah.
Thank you very much for a nice talk. Thank you.
Thank you very much. I can see is that Professor Samis Martin. Prof. Martin Samis, would you like to say something?
Thank you very much for fantastic presentation, and this translational research is very important for clinicians.
Thank you.
My question is, when you expect to use in clinical practice in these discoveries in the real bedside, or how we say, from bench to the bedside?
Well, yeah, that's a good question. So, yeah, actually, the result I showed today was all under the preclinical levels. So, but for the third presentation regarding the MNPO5, that is SOD mimic, that is the purpose of that study is the to test the clinical potential of the clinical translation. That's why we measure the PK profile at first, and we checked the very good BBB penetration. So that is, I hope, within, let's say, like 5 or a decade, we would like to move on to the clinical trials. Hopefully.
5 decades. 5 decades.
One a decade.
Mhm.
Hopefully.
Okay, thank you. Thank you. Right.
Yeah,
Thank
because
you.
yeah, and actually, yeah, as you may know, brain aneurysm is multifactorial disease. So, we need to combine multiple targets to create the actual preventive drugs. So, yeah, maybe we need to combine many of our results, I think.
Exactly, exactly. And a long way for preclinical and clinical use, of course. Yeah.
Yeah,
Mhm. Thank you very much. Excellent
thank you.
work.
All right, thank you very much, Prof. Martin. Just as Professor, you said rightly that aneurysms are different in different people. I was thinking always like you have created a mouse model of aneurysms, but how would it be actually simulate a human aneurysm study? You might have read the SWAVE study, right? Professor Sonobe, and in his study they have classified aneurysms into four types, which like form over a short time and rupture over a short time. And the second type are aneurysms that grow progressively for few years after its formations and then rupture. And type 3 are formed aneurysms which keep growing slowly for a few years without rupturing. And type 4 are aneurysm grows to a certain size and they remain unchanged thereafter. So, and like in the SWAVE study of Japan, 91.7 aneurysms were the type 4, which remained stable for a long period of time without rupture. So, if the aneurysm profiles are so different in different people, how can we emulate the translation medicinal studies into human practice?
Thank you, Dr. Raja. That is also really great questions, I think. Yeah, as you mentioned, Sonobe's classification is very famous. So I guess most of the ruptured case, I mean subarachnoid hemorrhage case, it sh- may be classified as type 1 or type 2, right? Because type 4
Right.
is very stable. So it is difficult to compare the time range between the mice and the human models. But actually, in our model, most of the aneurysms were formed within a week. I mean, within 7 days. And the rupture, most of the case, I mean, 80% of the aneurysms will rupture within 3 weeks, 21 days. So again, it is difficult to compare the time range between mice and human beings. But in terms of the Sonobe's classification, I don't know. It may be classified as type 1 or type 2. Mm, I have no good answer to your question. So it is very difficult
I understand.
to simulate all type 1 to type 4 aneurysms using our model.
Right. And nevertheless, we have to start somewhere. I think so. It is a good positive note in that direction. So thank you very much. We have Professor Hidehito Kimura from Kobe. He has done a lot of research in aneurysm. We'd love to hear from you, Prof. Kimura.
Thank you, Raja. Thank you, Raja, calling me. So, thank you, Professor Maeda. So fantastic and so informative and impressive presentation. I learned a lot. Thank you very much. So, my question is, what? My first question is, as you mentioned in your presentation, the senescent cell associated phenotype change cells. What these cells produce to injure to to progress the aneurysm rupture. So do you know what can cause to the aneurysm rupture? So that's why to decrease the aneurysm rupture, the main reason is maybe the phenotype changes of the senescent cells. My second question is MMP05. What is MMP05? So in that, as you mentioned, in the one decade, a decade, maybe we hope this MMP05 may be available for the clinical stage. What is the MMP05? Is it available now here in Japan?
Oh, no, it is under the clinical stage.
Oh, sorry. Just mentioned, yeah.
Yeah, so yeah, thank you, Dr. Kimura. First of all, I am not professor, so somehow my name was displayed as Professor Takuma Maeda, but I am just a young neurosurgeon. So
I recognize you. Yes, but I see.
anyways,
Yes, sorry. Thank you.
anyways, for first of your questions. So yeah, SASPs is, as I mentioned, SASPs are important for the development of the aneurysm rupture. But there is, SASPs involves a lot of cytokines. Among them, I think the most important ones were IL-6, IL-1 beta, and TNF alpha, and MMP9, which were well-known risk factor for the progression of aneurysm rupture. Actually, in a PCR study, we showed a significant reduction of these cytokines in the ganciclovir treatment group. So I guess, yeah, these 3 or 4 cytokines are one of the most important aspects,
All
important
included.
factors. Yeah, all included. Yeah. And also, we didn't see significant difference. BEZF may be involved for these pathways. And for your second questions, what is MNP05? Yeah, I'm sorry. Yeah, I know nobody is familiar with this name. Yeah, actually, this drug was developed in the Barrow Neurological Institute, IB Brain Tumor Center.
Really?
So for the defense of the oxidative stress. So simply saying, MNP05 is SOD mimic, manganese base. So actually, and SOD, as you may know, is an endogenous enzyme which converts the superoxide to hydrogen peroxide. So again, SOD is endogenous enzymes. So this drug mimics this SOD because SOD is center of the defense against the oxidative stress. So actually, human SOD contains a manganese base. So that's why this drug also has a manganese base, mimicking the human SOD.
I see. Yeah.
Unfortunately, I cannot show actual structure due to the patent issue of the drug. So,
yeah, but I see. Thank you.
Yeah, but this is what I can talk today.
Thank you very much. Yeah, understood. Thank you. Thank you. Great. Thank you very
Well,
much.
thank you very much. With that, we can wind up the first session. I would like to mention to our viewers that this has been broadcasted on YouTube, WeChat, and Zoom. And thanks to Professor Shubin. As of now, we have 735 people who are live on different channels in different parts of the world. So thank you very much, Professor Takuma Maeda, for taking your valuable time to teach us the various researches that are being developed in aneurysms, and we look forward to seeing the actual results and in human trials in future. Thank you very much.
Thank you.
Most welcome. So now we'll move on to the second session. Second chair is ready. Professor Makoto Sakamoto will say a short introduction about the VA dissection and invite Dr. Liu Chuang Hong for his lecture. Professor Sakamoto.
Yes, thank you. Good morning, afternoon, evening, everyone. I'm Sakamoto from the Department of Neurosurgery at Tokyo University in Japan. Now, it is my great pleasure to introduce our distinguished speaker today. We are honored to have Professor Liu from China joining us. Professor Liu is a highly respected expert in the field of neuroendovascular surgery. Today, we will share his valuable insights and experience on endovascular intervention strategies for vertebral artery dissection, which is a very important topic for all of us. Professor Liu, please start your lecture.
Good evening, everyone. I'm glad here. It's a very great platform for us to communicating. So I'm very honored and glad here to share my views on vertebral artery dissection with you. Intracranial dissection reason refers to a pathological dissection between the inner and the middle layers, or between the middle and outer layers of the intracranial arteries, leading to bulging and aneurysmal dilation of artery wall. IDA commonly occurs in the vertebral artery, followed by the basilar artery and the ICA. Today, we will focus on vertebral artery dissection, also known as VAS. Open surgery involves high risks for treatment-related morbidity and mortality, so an endovascular method is preferred in treating this disease. As we know, endovascular treatment is now well established as a major tool for treating intracranial sacral aneurysms. However, there are still many controversies in endovascular treatment for VAS regarding the indications, the selection of specific treatment methods, as well as the safety and efficacy. As shown in this picture, VAS can be divided into 4 types. First, type 1. Type 1 refers to classic dissecting aneurysm, which is the most common thing subtype. Pathologically, it is characterized by a rupture of internal elastic lamina of the artery wall, creating an opening that communicates with the vascular lumen without the accompanying thickening of the intima. It appears as irregular fistform or sacral dilation on CTA, DSA, or MRA. The lesions of this type are often accompanied by dilation at the distal or proximal artery stenosis of the aneurysm, and usually have no significant mass effect because the diameter of the intramural hemorrhage is usually less than 10 millimeter. Furthermore, we can observe typical intimal flaps and intramural hematoma in high resolution MRI images. Patients with ruptures present symptoms of subarachnoid hemorrhage, such as acute headache, nausea, vomiting, and impaired consciousness, while patients with unrupture may exhibit TIA or chronic headache. Most rupture lesions present an acute course, and when the amount of the bleeding is significant, the condition can be extremely dangerous. If not treated promptly, the risk of bleeding rate is very high, reaching up to 64.6%. However, unruptured cases generally have a benign course, and some may even heal on their own. For patients with type 1 who have experienced a subarachnoid hemorrhage and can tolerate surgery, early surgical treatment is recommended. If there is adequate compensatory blood supply and the vascular occlusion of the parent artery remains the most reliable surgical methods to prevent rebleeding under current technological and material conditions. So most of the time it's recommended as the first choice. When the application of parent artery occlusion is limited, it is recommended to choose stent-assisted coil embolization. It is particularly emphasized that reconstructive treatment using multiple stents combined with coils has advantages over single stent combined with coil in reducing rebleeding and recurrence. For patients with unruptured type 1 cases, if symptoms are mild or lesions are small, it is recommended to first observe conservatively and follow up regularly. If symptoms frequently occur during follow-up or continue to worsen, or if follow-up image shows that continuous progression of the lesion, and then endovascular treatment should be performed. The pathological of type 2 are segmental fusiform dilation, of arteries without intra or extra thrombus formation, and the dilation part has a relative symmetrical structure. This type of lesion is usually stable and in a chronic repair phase, so most cases can be observed conservatively. However, some studies have found that such lesions may not always be stable. During follow-up, the diameter of the lesion may continue to increase, and there is even a possibility of rupture. So the treatment principles for type 1 and type 2 are almost the same. They can be divided into non-constructive and constructive methods. The purpose of treating endovascular treatment for this type 1 and type 2 is to reduce or block blood flow within the dissection, repair the damaged intima, prevent the progression or rupture of the dissection, reduce the occurrence of ischemia events, and elevate symptoms of compression on surrounding brain tissue or cranial nerves. The first non-reconstructive measure is proximal occlusion of the parent artery alone, which is not recommended because after only occluding the proximal end of the parent artery, retrograde blood flow may still occur at the distal end of the dissection, leading to continued progression of the dissection, which can result in recurrence and rebleeding. The second way is to occlude both the parent artery and dissection. This surgical procedure is the most effective treatment for VAS, capable of simultaneous occluding both the proximal and the distal ends of the parent artery and the dissection, thereby preventing retrograde blood flow into the dissection part and thus avoiding its rupture and bleeding. It is considered the most reliable technique for treating rupture cases. However, it also carries potential complications such as postoperative bleeding, ischemia, and mass effect. Let's look at this case. It's a 57-year-old female patient who suffered from sudden onset loss of consciousness for half an hour, and the emergency CT scan revealed subarachnoid hemorrhage. Further CT examination indicated there is a VA dissection. From the CTA image, we can see that the bilateral VA have both developed well and are of equal size. The pica was not being affected, so either reconstructing the parent artery or occluding it is acceptable, since it is a hemorrhage case. Priority should be given to occluding the dissection and the parent artery. Bilateral VA angiography results were consistent with the CTA findings, so we subsequently treated the patient according to the preoperative plan. We can see the distal end of this anal region. This dissection is located at the conjunction part of bilateral VA. To maintain the patency of left VA, we first implanted a atlas stand in the left side, within the left side. Then we turn to the right side for the following coding. In cases like this, there is a sac-like aneurysmal structure branching to one side. It should be densely packed as much as possible because the rupture point often occurs at this location. In this case, we made densely packed of the aneurysm structure and 2 to 3 millimeter of normal vertebral artery near the proximal end. These are the final angiography. The DSA performed 5 months post-operation showed no artery dissection visible, both in right VA and left VA. Additionally, the left VA and the basal artery were in good patency. The DSA reviewed 19 months post-operation showed no recurrence of the dissection, with the left vertebral basal artery remaining patent. However, the follow-up DSA 4 years after surgery showed a recurrence of the dissection, primarily involving the left VA. So therefore, 3 months ago, we treated this case with left VA reconstruction by implanting an flow diverter device. This is a constructive method. So now let's turn our attention to the treatment strategy for vascular reconstruction. The first method is stent implantation alone. This procedure is generally mainly used for treating unruptured cases. After stent placement, oral antiplatelet drugs need to be taken for several months, which may increase the risk of bleeding. Therefore, using this method to treat rupture cases currently still has significant controversy. The principle of stent placement therapy for VAS is local hemodynamic changes promote thrombosis formation within the aneurysmal sac, while the radial support force of the stent compresses the intimal flap, making it adhere to the vascular wall, thus occluding the artery dissection. Additionally, the stent can serve as a framework for the attachment of new endothelial cells, promoting endothelial repair and achieving anatomical healing. Using conventional single-pair stent for treating VAS has a very high probability of recurrence. Studies have reported that using multiple overlapping stent placement techniques, increasing the metal coverage of the stent, or employing flow diverting stents can improve the efficacy of stent treatment for VAS. But the optimal type of stent and how to make a combination remain unclear. The second method is to use stent combined with coils. This procedure has become an important method for endovascular treatment of VAS. Theoretically, it can not only occlude artery dissection, but also maintain the patency of the parent artery. The effect of using stents combined with coils is superior to that of stents implantation alone. During the procedure, ensure that the stent covers the entire segment of the dissection after the stent deployment, and try to extend the stent at least 5 mm beyond both the proximal and the distal ends of the lesion to reduce recurrence and rebleeding rates. It's recommended to prioritize using high metal coverage stents or employing multiple stent overlapping techniques. One with field form dilated, just like type 2, it is often difficult to determine the rupture bleeding point. Typically, a coil embolization within the aneurysm sac is performed first, followed by the use of a post-release technique or semi-release technique to deploy the stent. This can further compress the previously released coils, achieving uniform and dense coil distribution within the aneurysm sac. When VAS branching to laterally, like case 1, the bleeding point is usually at the most prominent lateral part, Therefore, priority should first be given to packing the apex of the aneurysm, followed by packing the body and the neck of the aneurysm. And to reduce recurrence, a stent deliver catheter can be initially reserved, and the stent can be released using a post-release technique. Alternatively, the stent can be released first, and then embolization catheter can pass through the mesh of the stent for embolization. This is a multiple stent overlapping case. This is CT and CTA before surgery. From the CTA, we can see that the left VA developed well and is the dominant artery. The right VA was underdeveloped, with the PICA not affected. Therefore, we reconstructed the left VA by overlapping two Leo stents and embolize the aneurysmal structure with coils. This is 3D image. First, we perform the coiling of the aneurysm-like structure in the half diploid of the first Leo stent. The semi-release technique of the stent allows us to adjust the direction of the embolization microcatheter. Finally, achieving the goal of dense packing of the aneurysm-like structures located in different directions. After densely packing all aneurysmal-like structures in different directions, fully deploy the first stent. Subsequently, overlap deploy the second stent. This is the final result. In the end, immediate postoperative artery angiography showed that complete occlusion of the dissecting aneurysm, with the VA remaining patent. The DSA reviewed 3 months post-operation showed no recurrence of the dissection, and the left VA were in good patency. The DSA reviewed 16 months post-operation also showed good result. This is a case using FD combined with coils for rupture patients. These are CT and CTA pre-operation. And bilateral VA angiography showed that bilateral VA were well developed, but the right VA, the diameter of the right VA was slightly, the left side is slightly larger than the right side, and the PICA was involved by the dissection. So the constructive strategy was taken to ensure the patency of left VA and the PICA. After the first coil was placed into the aneurysm cavity, an involved flow diverter stent was implanted with the parent artery, followed by continued placement of coils until dense packing is achieved. This is final result. This is a case treatment combining flow diverting stents implantation with coil embolization. For unruptured case, in recent years, flow diverting stents have been increasingly applied in the treatment of such cases. Okay, let's skip this case. Okay, for type 3. Type 3 is a specific type of chronic dissection. This type is commonly seen in the vertebral basilar artery, where The affected artery shows abnormal tortuosity, elongation, and dilation, with significant intima thickening, accompanied by extensive thrombosis both within and outside the intima. The diagnosis of this type is mainly relies on images examination. Due to thrombus formation within the affected segment of the vessel, DSA cannot fully display the lesion, requiring further evaluation using MRI. Type 3 lesions generally have a poor prognosis and can present symptoms of brainstem ischemia and cranial nerve compression. As the lesion expands to a certain extent, it may also result in rupture and bleeding. This type of patient is more challenging to treat clinically, with higher surgical risks. There's no clear evidence yet on whether patient can benefit from surgery. Neither medication nor endovascular or surgical treatment have been fully studied on a large clinical trial. But there are some case reports. Some small sample case reports have documented occlusion of the parent artery and all combined with bypass surgery, which showed good outcomes in some younger patients. There are also reports of using conventional stents or flow diverting stents to reconstruct the parent artery. In some cases, symptoms were elevated. However, in other cases, despite successful vascular reconstruction, symptoms of brainstem compression or ischemia could not be improved. We have a case later. This is a case of type 3. In 2016, the patient underwent an MRI examination for cerebral infection, and the vascular abnormalities were detected. The next year, this patient also have a MRI follow-up. During the period of medication treatment and observation follow-up, serious image examination indicated that the lesion continued to progress. This is MRI 1 year later and 6 years later. And DSA 2 years ago. The patient experienced multiple episodes of cerebral ischemia and the symptoms of brainstem compression during a follow-up. And ultimately, this patient died due to aneurysm rupture and brainstem function failure last year. Type 4 refers to large mural bleeding ectasia. The affected segment of the vessel shows obvious large intramural hemorrhage, with hemorrhage at different stages visible within the hematoma, thus presenting an onion skin appearance on MRI images. Patients of this type mainly exhibit symptoms of brainstem compression or cranial nerve paralysis, as the thickness of the intramural hematoma usually exceeds 10 millimeter. During pathological section examination, proliferative nourishing vessels can sometimes be found within an intramural hematoma. This may be the most important factor that make this type particularly challenging to treat. Theoretically, lesion resection with or without bypass surgery is the most effective treatment method. But due to the lesion's compression on the brainstem, craniotomy for lesion resection often comes with significant surgical risks. If blood flow compensation is adequate, occlusion of the parent artery is the is the preferred treatment method, which can be effective for some patients. Partially elevating symptoms and maintaining stable regions on image follow-up. However, for minority of patients, even after parent artery occlusion, symptoms continue to worsen, with follow-up MRI imaging showing an increasing mass effect. Traditional standard reconstruction therapy for this type is unreliable and prone to recurrence. Currently, there are few reports on using new device such as flow diverting device to treat this condition, and its effectiveness needs further evaluation. Ultimately, patients with this type often die from brainstem failure due to the continuous enlarging mass effect. Take this case as an example. It's a case from Professor Qinghai Huang. It's a 52-year-old male patient who was found to have a vertebral artery dissection aneurysm upon examination due to dysphagia and left-sided hemiparalysis. Professor Fang treat this case use a two-bridge diverter stent. Angiograph 3 months later showed that disappearance of the artery dissection and good repair of this parent artery. But the patient's symptom did not improve. And the MRI image, we can see that MRI image suggested the dissection aneurysm continued to expand. The endovascular treatment of this disease still has many controversy points, with numerous aspects requiring further exploration and research to reach the final conclusion, which patient can benefit more. For example, how to combine stents when we're using multiple overlapping stents. The stent number and the stent type. So if time permits, I welcome everyone to join in the discussion together later. That's all for my sharing content. Thanks for your attention.
Thank you very much.
Thank you, Professor Liu, for your excellent presentation. I'd like to ask you a question, okay?
Mhm.
You mentioned type 3 and type 4 vertebral artery dissection is difficult to treat. What is the best treatment now for type 3 or type 4 dissecting aneurysm, do you think? My butter?
In my opinion, there are no optimal treatment for type C and type 4. We are still finding and it need more cases and you need more cases to and experience in this for these two types. And type C and type 4 are relative rare in clinical, and according to the treatment consensus in China, and literatures all over the world. Endovascular treatment and bypass surgery or other treatments. There are no patients. Usually they have poor prognosis. So maybe we can have a clinical trial combined with more hospitals, more clinical centers to get more clinical data to find this. We have treated this TAPSIN type 4 using flow diverter stents. There's one case just like Professor Huang, the last case. The patient suffered from ischemia events after surgery, and we also try to treat this disease using bypass surgery, but the long term, the mid term and the long term results were not good. So this is very this is a question need us to further research and evaluate the efficacy and safety.
Fine.
Any other question or comment
So
from
far,
audience?
Can I ask you
Yeah,
simple
sure.
questions? So the first case you showed me today, so I guess the dissection involves both vertebral artery, right? So
Yeah.
so in that case, also it may be stupid question. Can we perform the parent artery occlusion of the both vertebral artery and or proximal surface of the BA if the patient have very good PCOM, or if we can combine the bypass surgery? How do you think of it?
This is a case 4 years ago we at least we have, and it's an emergency case. And at that time, we don't do much bypass surgery for post circulation. So in my center, it's an emergency case, and my limited to my technique and experience. So we don't consider this method. It's a huge work to accrue the bilateral VA and mid bypass. Maybe need high volume bypass, and STA to PCA or maybe to maybe not adequate, not sufficient. And I think to treat a patient, not only to consider the patient's condition, also you need to combine your experience, your technique, and the condition in your center. So maybe in a big clinical center, this strategy, we can try this strategy. Yeah.
Thank you.
Thank you. Thank you
Good
very
question.
much. There are no further questions. We can hear your concluding remarks, Prof. Sakamoto.
Thank you very much, Professor Liu, for sharing your valuable experience with us today. I'm afraid we've run out of time, so we'll have to conclude today's session here. Okay.
Thank you very much, Prof. Makoto Sakamoto and Professor Liu Chuang-Hong for this wonderful lecture. On behalf of the Education Committee of the ACNS and the President, Prof. Yuko Kato, I would like to thank both the speakers of today, Prof. Takuma Maeda and Prof. Liu Chuang-Hong, and the chairs, Prof. Martin Chames and Prof. Makoto Sakamoto, for the time and support for the ACNS webinars. Also special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and as I said earlier, we have around 735 people who have joined us live from different parts of the world. A special thanks to my co-host Dr. Liu Bun Singh for joining me today. Until we all meet online tomorrow, it is bye bye from all of us. Thank you very much for joining.